Welcome, everyone. I know that we'll have a few more people joining. My name is Jennifer Noel, and I am the Program Manager for Education and Outreach at the University of Vermont Center on Rural Addiction. I'm also here with Nellie Stidham, who's a research assistant and who has done all of the organizing for this webinar. Thank you so much for joining us today. The Community Rounds Workshop Series is a live webinar series held monthly by the UVM Center on Rural Addiction to provide opportunities for health professionals to learn and ask questions. We discuss topics related to science-based best practices for substance use disorders. Sessions usually include about 45 minutes of presentation, followed by 15 minutes for questions and conversation, although Dr. Lin has said that people are welcome to ask questions during the session in the Q&A box. Before we begin today's session, I'd like to go over a couple of reminders. We do encourage you, like I said, to ask questions, and you can enter them into the Q&A box during the session. Dr. Lin will do her best to answer them during the session, and we'll also address them during the Q&A period at the end. If we run out of time for all questions, we'll follow up with you via email. The presentation is being recorded, and a recording of the session and the slides will be shared following the presentation. You can expect to receive them via email in a few days. If people are comfortable, some of you already have, please do use the chat box to introduce yourself to the group by sharing your name and your organization and what community you are coming from. It's really exciting for us to see folks from all over the country, as well as New England, showing up. We also recommend that you choose speaker view during the webinar so that you only see the presenter speaking and not the other panelists who may be on the webinar. It's just a little bit less distracting while you're watching. Continuing education credits are available for those who attend this session live. We'll share the link in the chat box during the session for instructions on how to claim your credits. And you'll also get instructions via email when you receive the recording and the slides. If you have questions, you can contact us at cora@uvm.edu. And we do ask that you claim these credits within 30 days of the live webinar. There are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So at this point, I'd like to welcome Dr. Peter Jackson, who is Assistant Professor at the University of Vermont, Larner College of Medicine and UVM Medical Center. He is here today to introduce our speaker, Dr. Allison Lin. So thank you, Dr. Jackson. I will turn it over to you.
Awesome. Thanks so much, Jennifer. I'm so excited that we get to hear from Dr. Lin today, and so grateful that she was willing to accept the invitation to come and talk. She is an addiction psychiatrist and an assistant professor in the Department of Psychiatry, and she's also a research scientist at the VA in the Ann Arbor healthcare system. She has many leadership roles. She's the president of the Michigan Society of Addiction Medicine. She's the co-director of the Michigan Opioid Collaborative, and she serves as the co-chair of the research committee for the American Academy of Addiction Psychiatry. She has been investigating ways to improve treatment for patients with opioid and other substance use disorders using large electronic health data sets, working to better understand mental health and other correlates for patients affected by substance use disorders. She is nationally recognized as an expert regarding telehealth interventions to improve access to evidence-based treatments for substance use disorders, especially opioid use disorders, and works to better understand disparities in treatment. Her success and accomplishments in her research and in her clinical work comes from her impeccable character. I had the privilege to share part of my training experience with her, recognize her as a great colleague, a wonderful friend, a wonderful person. And so please join me in welcoming Dr. Lin. Thank you so much for coming.
Thank you, Dr. Jackson, for that introduction. I would also like to highlight maybe some of your background. I think Dr. Jackson and I completed our residency training at University of Michigan, and we were very, very sad for him to have left and to be working now in Vermont, because he's really one of the most amazing clinicians, as well as overall psychiatrists I've ever worked with. And so just wanted to put that out there as well. And thank you very much for the invitation to present here. So I'm going to go through some of these initial slides, unless Jennifer would like to mention anything else. I think these are some of the things to highlight the work on CORA. It's amazing to see all the work that you guys have done, this workshop series, in addition to the other work that you guys have completed through HRSA and other bodies. Okay, let's see. Maybe just to highlight one more thing, the next community rounds, it sounds like in September, is going to be featuring these speakers in this topic, which is very exciting as well. I do know that these are some of the key kind of scientists in this area of peer recovery, which is a really, really important topic as well. All right, so today I will be presenting on the topic of telehealth for substance use disorders with a particular focus on considerations for rural regions. The main objectives I have today include discussing the evidence and methods for telehealth for substance use disorder care. Also really describe how treatment has evolved during the COVID-19 pandemic, identify and highlight some of the regulatory and prescribing considerations for telehealth, specifically for rural communities. Identify methods and alternatives for monitoring, which is one of the key clinical questions I get from clinicians for substance use disorders for remote rural patients. And finally, considering challenges and opportunities for SUD-focused telehealth in rural regions, and really the practicalities of how do you do it, what are the challenges, and how to overcome them. So I'm very open to taking kind of questions, thoughts, because my guess is a lot of the folks in the audience have actually been practicing this. You know, all of us really kind of delved into a whole new world in the last year and a half. And these are really kind of day-to-day practicalities that we're thinking about all the time. So happy to kind of discuss some of these things here. In line with kind of what I just mentioned, this is the outline for what I'll discuss. I'll really focus on some of the evidence and research, but really kind of in the background for why this topic is important, but hopefully also talk through clinical case examples, highlighting some of the clinical challenges I just mentioned. These are my acknowledgements and disclosures. So this is a very broad background slide. Some folks will have seen some of these figures, but most will not have seen all of the figures here, which are all from the CDC, which collects and shares overdose mortality data across the United States. The one on the top left is really focused on opioids. The 4 green lines represent the specific subtypes of opioids, including synthetic opioids such as fentanyls, natural and semi-synthetic opioids, which are predominantly prescription opioids, heroin, and methadone. And what has been known for a long time now is that really the opioid overdose epidemic has evolved in the last 7 or 8 years away from prescription opioids and really one towards synthetics like fentanyl and heroin, meaning street opioids that people are using. The key thing here, though, is that the epidemic and the epidemiology of this really varies tremendously across states in the US and across regions, including rural and non-rural areas. It's really important to think about kind of the overdose epidemic both locally. So what are the key things that your particular community is experiencing in addition to the national context. The second and the third panels, I think, are less, have received less national attention, but are just as concerning. The second panel highlights the mortality in this country related to stimulant overdoses. And if you see the curve, the slope of that curve actually looks very similar to the opioid epidemic, but has really been highlighted much less. The two figures are really mortality rates due to people who died from stimulants alone, which includes both meth, cocaine, and other stimulants, and those who died a combination of stimulants and opioids. And what's interesting is that the phenomenon of stimulant overdose epidemic really includes those who are combining them with opioids, but also alone as well. And this is really an issue that I think has been under examined and really is very pertinent to the rural communities, because we know that in rural communities, particularly with meth, the overdoses have really skyrocketed. Some of that is due to contamination of the stimulant supply with synthetic opioids, but some of it may not be too. So this is a really important thing for all of us to understand. And lastly, on the right panel is really kind of a figure that highlights not overdose, but general all-cause mortality related to alcohol. And the key thing here is that alcohol is still the most prevalent substance use disorder and is associated with the highest overall mortality rate compared to other substances. And this is really saying that, you know, in the US, we're not just facing one overdose epidemic, we're really facing an epidemic of addiction-related impacts, in addition to the pandemic, unfortunately.
Dr. Lin,
Yep.
Here's me interrupting with a question. We have somebody asking the question, and I think this is a good sort of basic question to get out of the way. Is telemedicine the same thing as telehealth?
Sure. So I can speak to that. It's funny, I was having a debate with someone about this just yesterday. The answer is that it really, those two terms have become so interchangeable in the general literature these days that it's important to define it. So in some communities, the word telemedicine used to mean video delivered care, direct care, meaning kind of Zoom, face-to-face with your patient, you know, provider in one location, patient in another location, and synchronous care, meaning you're talking and seeing each other at the same time. There's also the broader, you know, strategies used in virtual care delivery, which can include, for example, you know, our colleagues in radiology might do, you know, non-synchronous care where someone is reviewing an image and providing virtual consultations, but not at the same time with the patient in front of them. And so telehealth sometimes is used to encompass the broader array of technologies used in virtual care, but to be honest, they're almost used interchangeably these days. So it's really important to be precise whenever you use those terms to define that for the specific context. And I'll definitely be emphasizing that when I talk more about those a little bit later.
Thank you.
No problem. And so the last piece kind of about alcohol, just wanted to emphasize again that, you know, all of these substance use disorders, the most common substance use disorders being alcohol, cannabis, stimulant, opioids, really cause quite a lot of impacts, not just around mortality, but also morbidity as well. And so this is just a brief slide kind of emphasizing the impacts of alcohol, not just on death rates, but also on costs and functional impacts in the individual, but also their family and their communities. The thing to highlight here, unfortunately, is I've been doing research on telehealth for maybe 5 or 6 years and have been practicing telehealth as a VA addiction psychiatrist in the substance use disorder clinic for over 5 years. And it was funny because I would be giving these talks, you know, 2 or 3 years ago, and it would be to a small audience because there was only very few of us who were utilizing telehealth back then. Obviously, things have changed dramatically since COVID-19 when it comes to telehealth. Unfortunately, a lot of things have changed since COVID-19 when it comes to substance use as well. We know that in the setting of the tremendous stressors, in the unequal distribution of some of these stressors on families and individuals, that likely has contributed to increased substance use across a host of substances. What we also know from some of the preliminary data just in the last couple months is that overdose rates, although there was already an epidemic of overdoses before, have actually skyrocketed further since the pandemic. I think a lot of us are trying to understand exactly what's contributed to these further increases in overdose mortality rates. But that's just one thing to emphasize is that within the addiction community, what we're really facing is an epidemic of addiction and overdose on top of the pandemic. And the challenge with that is obviously, you know, in order to try to mitigate some of these impacts from mortality and also morbidity, it's really important to think about care delivery. And this is kind of what the focus of today's talk is. We know that, you know, long before COVID, very few people with substance use disorders were receiving treatment. The national estimates show something like 21 million Americans have a substance use disorder, but only about 10% receive treatment. Of note, I'll point out later some of the barriers to treatment. And these are barriers similar to other chronic illnesses like mental health disorders, like depression and bipolar disorder, which also face a lot of stigma. But the key thing is that treatment rates for substance use disorders are even far lower than those for other mental health disorders. And we can discuss some of the reasonings for that. One of the reasons, though, beyond kind of the system-related reasons and stigma that I think is very much there, is that there's even less or fewer addiction-trained clinicians and specialists compared to other mental and behavioral health clinicians. In particular, the figure here shows the distribution of addiction psychiatrists in the United States. There are many other addiction physicians as well as addiction-focused therapists and other clinicians. But as just one view, this is really where the very small number of addiction psychiatrists are located in the US long before COVID, which means that the vast majority of counties in this country do not have access to any addiction psychiatrists. And if I showed you the figure for addiction physicians, it would actually be very similar in terms of little access to addiction specialist physicians.
Dr. Lin?
Yep.
We have a question about whether this would include physicians or providers who do tobacco and nicotine addiction, as well as other substance use disorders.
Yeah, so that's a good point. So this figure is from the Behavioral Health Workforce Center, and this focuses only on addiction psychiatrists who oftentimes may be also delivering care for tobacco use. So it's not specific to any substance use disorder. What I would imagine, though, is that if there was the data that also focused on treatment for tobacco use specialists, it might be more because I think there's more available treatment within healthcare systems and such, but still very much underutilized and underavailable. The key point, though, is that what's really unfortunate and what's, I think, most frustrating to folks like me is that it's one thing to say, okay, we don't have access to treatments if we didn't have treatments, but we actually do have effective treatments for substance use disorders, and I'll highlight just two kind of categories. For alcohol use disorders, which again is one of the most common substance use disorders outside of tobacco, we do have effective medication and psychotherapy treatments. So both medications and counseling treatments, and we've had them for decades, specifically FDA-approved medications like disulfiram, naltrexone, acamprosate, and none of these are controlled medications. On the psychotherapy side, we actually have probably even broader array of options, including cognitive behavioral therapy, motivational interviewing and enhancement, contingency management, and other effective multi-session psychotherapies. And these have been shown by decades of studies that they reduce negative outcomes, they reduce alcohol use, and can really enhance outcomes, including quality of life for patients. Similar to alcohol use disorder, we have effective treatments for opioid use disorder as well, which again is one of the substance use disorders that carries very high mortality rates. Currently, the effective treatments are 3 medications: methadone, buprenorphine, oftentimes formulated alongside naloxone, and naltrexone. The first 2 medications are controlled medications. They're both opioid agonists, or they're both opioids themselves. And the third one is an opioid antagonist, or it blocks the effects of opioids. The simple figure on the right kind of highlights just how differences in how they work. The most important thing here to emphasize is that it's really important that we have all 3 tools in our toolbox. Addiction, including opioid use disorder, is very complex and has such tremendous impacts, and is oftentimes a huge challenge for both the patients and providers. And it's just really important that we have as many tools as we can have in our toolbox, because different patients will respond to different treatments. We know these days that the best first-line treatments for opioid use disorder are likely the first 2 medications, and probably these days more often buprenorphine, just because of the office-based availability of it. Methadone to date still has to only be not prescribed, but instead actually dispensed within a methadone treatment program, and there are very few of those. I'm not sure what it's like in Vermont, but I know in Michigan, there's actually not a single methadone clinic in most of the northern parts of the state, which covers, tens of thousands of square miles. And so a treatment like this, which requires patients to oftentimes present to the clinic daily to obtain a dose, very quickly becomes inaccessible if there are so few clinics out there. That's why the medication buprenorphine and naltrexone, when they became available, were very promising, because these medications can actually be prescribed, specifically buprenorphine. Naltrexone, the effective formulation is actually a month-long injection. So it's oftentimes actually administered within clinics, which also makes it a little bit more challenging to administer in rural communities where this is really requiring patients to have to present in person. And so a lot of the discussion I'll focus on today for opioid use disorder, at least, will more focus on the medication buprenorphine, just because it's probably the most feasible option when it comes to telehealth delivery. Just to highlight again, with opioid use disorder, like alcohol use disorder, these treatments are backed by decades of research, multiple meta-analyses, and systematic reviews. Not only are they associated with reductions in opioid use, and also through numerous studies, reductions in mortality, right? As a psychiatrist, I would say, not just an addiction psychiatrist, there's not a whole lot of treatments that I deliver or have in my toolbox that I know for a fact can reduce the likelihood of death in my patients, besides these medication options for opioid use disorder. It really underscores how important these options are. They also improve lots of other key outcomes, such as functioning and quality of life for patients as well. So now I want to move on to kind of the challenges, right? So we know there's major problems in terms of people dying from substance-related causes and many other negative impacts. We know we have many effective treatments for some addictions, both medications and psychotherapy. For others, some medications alone or psychotherapy alone. So what are the challenges? Yet only less than 10% of people are getting treatment. So what's causing this, or why? The way I like to think about this is from an overall perspective. I like to think about kind of the reasons in 3 boxes. The first is stigma. The second is the limited accessibility of care. And the third is really the underlying disease itself. And so stigma, I'll actually talk a little bit more about later, but I really mean that both in terms of the stigma affecting the individual suffering from the illness, as well as many other layers, including within healthcare systems and the society at large. And the other key box to emphasize here are the complex symptoms of addiction. This is one that I think oftentimes is very appreciated by families, but less appreciated, I think, when we think about the research, which is, by definition, the disease of addiction is defined as an illness where people are ambivalent or don't want to stop it, and thus are ambivalent about care. So the fact that, this is an illness, unlike all other chronic medical illnesses, the additional layer is that the illness itself makes it more challenging for people to engage in care. And, for a long time, we thought, oh, well, this means that, we have to wait until people are ready. But what we also haven't factored in is that because this is a symptom of the illness, we should really be thinking about treatments that treat and address the symptom of ambivalence as well. And we do have options, including motivational interviewing, to help better engage people in treatment. And I would contend if we made treatments better and more accessible, it might actually reduce some of this barrier too. The last category is the one that I will be focusing most on, is really the limited accessibility of care. And I'll spend more slides talking about that. But just to emphasize, in national surveys, specifically from the National Survey on Drug Use and Health, all of these reasons within these 3 categories have been described from patients as major barriers to care receipt for their substance use disorder. One thing I want to further emphasize that I think is under-recognized is within that accessibility category, distance to care is a particular barrier for substance use disorder treatment. We know from prior research studies that distance has been described as by patients as a major reason for discontinuing or stopping care, and also a major reason for not following up with care referrals. So even when the illness has been identified, the longer the miles it takes to get to a care clinic for patients with SUDs, the less likely they are to receive treatment. I think that this is important because there are certain things that we can actually think about changing, and that's the way that we deliver care. When you think about substance use disorder treatment, particular for some treatments that require ongoing care, for opioid use disorder, we're talking about oftentimes about people staying on buprenorphine for, at least a year, if not much longer than that. And in fact, the goal of treatment is oftentimes on continuing them in treatment as the primary outcome. But oftentimes, the way that we've been thinking about treatment traditionally is that patients do have to come in regularly, potentially weekly, for psychotherapy. And then for a really long time, many of us, no matter who you're talking about, would have a really hard time adhering to these care practices, especially because sometimes when patients no-show, we oftentimes, it's a reason for discontinuing the care, unfortunately. And so distance really exacerbates some of these ways that the care is set up. And the last thing is that it's a particular barrier for this patient population. So I work in the substance use disorder clinic at the Ann Arbor VA. I would say the vast majority of my patients have, at best, unreliable transportation. In a research study where we were doing phone-based qualitative interviews with veterans with substance use disorders who weren't in care, we asked them, as like the last, parting question, what's the one thing that could actually help you get into treatment? And one veteran said it very succinctly, and that's easy, a car. It's like, okay, we can do all of these other things, but if we kind of overlook the simple realities that our patients face, we're really not going to be able to address some of these problems.
Dr. Lin, we have a question that is sort of on this topic. Somebody is asking, in California, I've had big challenges getting naltrexone injection, Vivitrol, covered by insurance, and wondering if you have any thoughts or advice about that.
That's a very good question. That raises kind of the other side of things, which I didn't highlight, which are some of the other system-related barriers when it comes to reimbursement and things like that. We could have a whole other talk on those types of challenges. Reimbursement for different treatments is a major issue, and it is so dependent on where you are, what insurance the patient has, which kind of clinic or practice you have. I guess what I can say is, I know this is not directly answering your question, so I'm going to put on my another hat more from kind of an advocator in our state. In the state of Michigan, Michigan only recently passed a piece of legislation that allowed for clinic-based treatment of alcohol use disorder and opioid use disorder using medications and psychotherapies to be reimbursed for Medicaid patients. Like, this only happened officially, at least, very recently. And it was really kind of made possible by quite a lot of advocacy in the community. And so I guess what I'm saying is it's a huge challenge. It really affects the work that we do, but progress can be made if you think about ways of reaching the state. For example, in the state of Michigan, the Michigan Department of Health and Human Services has kind of key leaders who are really focused on substance use disorder treatment. And due to advocacy of some of the community members on highlighting these issues around reimbursement, it really was able to make some changes over time. That's not an easy answer, I know. Okay, so now I'm going to turn to the topic of telemedicine. As I mentioned, I would try to define it very specifically. What I mean by telemedicine for this talk is really synchronous or live video conferencing. So meaning direct care delivery with a patient in a different location at the same time via both video and phone. And that's how it's traditionally been defined. It hasn't covered in the past other types of virtual modalities like store and forward and things like that. And also many other virtual modalities like text-based interventions that have been looked at in research. The key thing that's really changed, though, since COVID is really phone delivery of care, and I'll focus on that in a little bit too. I will mostly be focusing in this talk on the video platform, so basically seeing patients via Zoom or some other video platform, but I'll also touch upon telephone delivery of care too, just because of how common it is used since COVID. I won't be focusing so much on the other virtual modalities. Okay, so effectiveness of telemedicine. So long before COVID, there had been many decades of studies of telemedicine for lots of other chronic medical and mental health issues. We know without a doubt across numerous large systematic reviews that telemedicine delivered care is non-inferior, meaning it's no worse than in-person treatment for many chronic illnesses such as mental health conditions. So there are numerous trials that have been conducted for things like depression, PTSD, other conditions. However, those studies have also highlighted that telemedicine, beyond just not being any worse than in-person care, those studies have also included that telemedicine can sometimes improve other or reduce other barriers such as stigma. For some of our patients, right, you can imagine coming to a specialty clinic itself, waiting in that waiting room, calling for treatment, things like that itself can be very difficult, and that alone can be a barrier. So prior studies have indicated that potentially offering telemedicine for patients at home where they can receive care within the comfort of their home can potentially reduce some of that stigma barrier too. Although I would say a lot more studies are needed in that area. However, the challenge really comes down not on exactly delivering telehealth, but it's really about kind of the logistics, including the patient-clinician rapport. How do you maintain that? How do you enhance that via kind of a video session? The technology challenges that are very common, and those types of issues. And so this is kind of really a review of the non-SUD based studies, that there's really quite a lot of research out there. Unfortunately, there's been far fewer studies when it comes to telemedicine for substance use disorders. Like I said, we obviously have good evidence from other conditions to inform telemedicine for SUDs, but we wanted to see what has actually been done in the SUD world. And so myself and colleagues in California a few years ago conducted a systematic review that was published in the Journal of Substance Abuse Treatment, and we really looked at the entire sphere of literature, including published and unpublished studies, not just randomized controlled trials, but the entire sphere, including observational studies and things like that, to look for studies that examined any form of telemedicine for substance use disorders, including nicotine and tobacco. And what we found is that there were far fewer studies. There was only a little over a dozen studies in total, and they focused on tobacco use, alcohol use disorder, and opioid use disorder. And most of the most rigorous studies were actually conducted for tobacco use. There were a few randomized trials for alcohol use disorder and no randomized controlled trials for opioid use disorders. What we found in summary is that there are some indicators of comparable alliance and retention in care between telehealth versus in-person care, but really there's just not been enough research to date. There's no what we call fully powered studies, meaning they had enrolled enough participants to fully flesh out these questions. So I think from this literature search, it's really that telemedicine, I think, is very promising. It makes a lot of sense for substance use disorders, but there's open questions out there. The key questions that I actually think we need to answer is not just how telemedicine compares to in-person health, in-person care delivery, but really kind of the broader questions of, if we offer telehealth or telemedicine to patients, let's say in rural areas, who may or may not have been able to access any form of in-person health care, like, does that improve their treatment rates at all? So that comparison arm is really important. Also, there's lots of different models that we can think of. Some of us work in healthcare systems that have really turned to things like collaborative care, expert models, and things like that. Can we embed telemedicine within other models to reach a broader population outside of traditional addiction care, for example? And really understanding patient and clinician experiences, preferences, and ongoing barriers, for example, technology. So that some of this work is ongoing. I think we need a lot more studies to date. Next, I really want to highlight, okay.
Sorry, I'm not sure if this was sort of partially addressed, but we did have a question about drug testing. Somebody said, what's the importance of regular drug testing when using a telemed platform, and how do you recommend getting patients to adhere?
That is the #1 most common question I get asked out of probably 24 national presentations I've given on this topic. I have over one slide where I talk about that. So hold on to that question. If I don't fully address it, we'll definitely talk more about it. Okay, so what changed then with COVID-19? Interestingly enough, before COVID, like I mentioned, there was a small group of people who were using telehealth, oftentimes in rural areas, actually, or in areas where it really had a shortage of clinicians, which is not just specific to rural. For example, in the Ann Arbor VA, we also deliver care to one of our community-based clinics in Flint, Michigan, which did not have any addiction practitioners. And so prior to COVID, I was seeing a lot of our Flint-based clinics via telehealth. Back then, though, it was actually, we were doing telehealth where I was in the medical center and patients were presenting to a community clinic, so they weren't presenting at home. And that's really changed since COVID-19 dramatically. So there's really also been quite a number of both federal, state level changes to decrease barriers for telehealth, specific actually, even to substance use disorders since COVID-19. Myself and colleagues summarized some of these changes in a viewpoint that we wrote in JAMA Psychiatry last year. So for more details, you can go there. But there's really great resources that I'll also present later that highlights some of the changes that have occurred. And those changes occurred at the guidance level, at the reimbursement level, at the really kind of along the lines. It's very complicated to think about, but currently, at least, a lot of us have really dramatically turned our practices to telehealth. One question that I'm sure will come up is what's going to happen after COVID? And the answer is we're not quite sure what's going to happen. Congress is currently looking at a lot of these questions. The rate at which things might change is actually dependent on how things are affected by COVID. And so I think these are some open questions that are important to discuss too. I'll just highlight a number of the key changes, focusing on not just broadly substance use disorder care via telemedicine, but also really pertaining to something like opioid use disorder. And so the key changes, one is really kind of the loosening of the Ryan-Haight Online Pharmacy Act. This is really kind of a key piece of legislation dating back well over a decade that was really there for, it governed really any prescribing of a controlled medicine, including stimulants, benzodiazepines, but also buprenorphine as a medication. And pre-COVID, this was a barrier to people doing telemedicine. And what it meant was that before you initiated care with a patient via telemedicine, they had to have been seen in person first, which sometimes is not a major barrier, but really made it very difficult to use telemedicine for buprenorphine care. In addition to loosening this kind of constraint in COVID, which the federal public health emergency is what it is. That was actually an exemption within this piece of legislation, and currently we still lie in a public health emergency until it's fully revoked. And so this is why things can change very quickly in this landscape. In addition to that, though, there are many other changes and guidances that have been issued by SAMHSA, DEA, payers, and many others. A key thing, I would say the number one biggest policy impact is really about allowing the use of phone visits, both for controlled medications like buprenorphine, but also just in general, across all healthcare. That has really made a tremendous difference. In current research that I'm conducting in the VA, and we've seen this data outside of the VA as well, as it's just been remarkable how much healthcare delivery turned to telehealth, like where it's now the predominant mode of healthcare delivery just a year. And a lot of it actually is being conducted by phone. And there's real questions there that we can touch upon later. For opioid use disorder, just to highlight, there's also been increased take-home days of methadone care. That's made it a little bit more accessible. There's lots of other changes when it comes to regulations. So privacy changes, HIPAA changes, reimbursement changes. So it quickly gets very complicated. One question that I often get from clinicians is, how do I make sense of all of these changes? Some of us are working to put together some guidance and toolkits for clinicians that hopefully will be available not too long in the future to help people at least have resources that are collated together that makes it easier for clinicians to think about some of these questions.
Dr. Lin, we have a lot of questions coming in, so I'm sorry to interrupt. This person is asking, he says, our agency has seen a 28% decrease in no-shows in our rural area when treating substance use disorder. Is there a study on, since COVID-19, that shows the effectiveness of telehealth in rural communities? And are there studies happening currently that we as behavioral health agencies could participate in?
I love that question. So as a clinician, this is the number one thing I noticed too. Honestly, so what's challenging about studying this question during COVID is obviously a lot of things are changing, right? Not only are we delivering care via telehealth, obviously the context, our social context has changed so dramatically. But the other thing that's changed is not only are we doing telehealth, the way like our clinic policies and the way we conduct visits have also changed. For example, we're delivering a lot more care management for patients. For example, in our clinic for my SUD patients, when patients no-show, I call them now. And I totally agree. My no-show rate has gone almost to zero because you can always locate patients most of the time. And that's tremendous because, one of the biggest barriers previously was that it was very difficult for patients to adhere or to be retained in care, right? To stay engaged in treatment. And so it's not just telehealth, but really kind of how we approach care has changed. Some for the better, like in this example. Obviously, there's a lot of challenges with COVID, but I totally agree. And so what I'll mention is that currently we have a paper or a research study underway where we're looking at telehealth specifically for opioid use disorder in this case in the VA. And then we're also looking at telehealth for alcohol use disorder as well. This is kind of preliminary data, but what I'll mention is that in some disease entities, we actually have found that care retention or overall care delivery has actually improved and increased related to some of these changes that I mentioned. However, I do think that for some populations, care utilization might also be going down because what also happened with COVID is that, patients are staying at home and they're not even engaging in other forms of care like primary care or coming into the hospital. So sometimes I would hypothesize there is the potential risk that fewer patients are identified. And this is borne out in a study. I'll just kind of fast forward to this slide. So in a study that looked at privately insured patients across the United States, this was published by Hayden Huskamp and colleagues last year. What they found was, at least in opioid use disorder patients, and this was really only in the first couple of months of the pandemic, so March and April and May of 2020, what they found was that the proportion of patients receiving opioid use disorder medication was really unchanged, which is a very good thing given how big of a disruption COVID was. They also found that the rates of urine screens went down pretty substantially in the second figure that you see. The last point that they noted was that, however, there's a big difference. What they found was that the number of patients who were already in treatment, who were already on buprenorphine pre-COVID, those were the patients who actually stayed in care even longer or continue to stay in care, meaning their treatment rates didn't differ. But there was actually a decrease in patients initiating treatment. And those are the patients I worry about even now, is the people who we knew, who we felt comfortable with. I would say that there's research evidence to show that clinicians were fairly comfortable delivering care to those patients via telehealth. But then the patients who, let's say, had undiagnosed substance use disorder, which we know is like the 90% of patients, those who were previously not engaged in care, I worry that those rates of treatment might actually be going down. And we're doing studies to try to understand some of these barriers and try to further address them too. So I'll kind of talk about, this is, I think, really getting to the points where I think a lot of folks here are also very interested in, which is the logistics and really what's next. As I hope I highlighted, it's that, since COVID, there were quite a lot of changes, both at the federal and at the state and local levels that removed some of the barriers to telemedicine and telehealth, phone, video, and other modes of treatment. The challenge is the uncertainty, like how do people make sense of this? How do they know what's better and worse practice for all of us as clinicians who we're trying to deliver the best care that we can, but having to do so in a very different way, meaning if we're trying to reduce frequency of urine screens to enhance social distancing, what does that mean for outcomes? There's really not been research to kind of inform some of these questions. And these are really key questions. And I'm hoping that in the absence of research, which is underway, it's important for all of us to be talking about the pros and cons of these. The other things that are really important to continue to talk about is really the logistical barriers. So technology remains a major logistical challenge. So although we know that something like over 90% of people in the US have access to the internet, first of all, I would say in our patient populations, the rates are likely lower than that. And also, it's one thing to have access, it's another thing to have reliable access. And these are issues that we face all the time, which is why a lot of care has really turned to phone delivery rather than video. And we can talk about different ways of addressing that. And the other question as a clinician is, okay, it's one thing to treat some patients, but as a clinician, I think what I hear a lot about from other folks is really that uncertainty, the discomfort about treating care in a different way than we had ever been trained in medical school, which is how do you care for a patient who has very complex condition, oftentimes using multiple substances, have multiple other comorbid disorders, including mental health and other medical illnesses, and treating them at a distance when you've never even potentially seen them. How do you feel comfortable? How do you develop rapport? How do you kind of engage them in treatment? What I would say is kind of the thing that I think about most often when it comes to trying to answer some of these questions, because there's no easy answers, is really thinking about it with kind of being as patient-centered as you can, meaning what are the realistic options for this patient? What happens if you do X versus Y, right? Meaning there are consequences no matter what approach we take. And we try to do the best with the constraints that we have now. And I'll kind of illustrate that with a patient example, specifically around the question of urine screens. One thing I just want to highlight is that we are also trying to collect some information or research data on experiences of both clinicians and patients when it comes to telehealth, because a lot of what we have, so far is really anecdotal. In a current study that we're conducting with patients with both alcohol and opioid use or opioid use disorders, we really kind of ask them about their experiences. How do they feel about it? What are the barriers? What are the ongoing kind of reasons? Have there been positive or negative effects, things like that? And what we found is that it actually really depends on the patient. And I would suspect that this is true no matter where you are. And that's that, yes, there are benefits of telehealth. Those include convenience, decreased stigma, and these are quotations that are illustrative of some of these points that you can read through. But not everybody feels that way about it, and not everybody feels positively. I have patients who tell me, the day that you're back in person again, I'm going to come to see you in person. Doesn't matter how far I have to drive. And so what's interesting is that pre-COVID, we really weren't offering a whole lot of telehealth. During COVID, for some of our clinic settings, we're only doing telehealth, meaning patients don't have a choice either. We don't have a choice right now. The question is, what is care going to look like in a post-COVID world? What I would like to say is that hopefully we'll have more choices to offer, both for patients as well as clinicians, meaning hopefully we'll have a better understanding of which patients might do better with telehealth, which patients might do worse. Where is it that they have a real option? Do they have an option? For many of our rural patients, in-person care might not be an actual option. So if that's the one option we present them, then we shouldn't be surprised if they're not engaged in treatment too. And really kind of the ongoing challenges, which I think have a lot to do with technology and comfort level, both on the patient side as well as the clinic and the clinician side. Okay, so I'm just going to walk through a basic quick patient case. And what I'm hoping to do here is really illustrate some of the clinical issues and bring more questions for our discussion. So this is where I'm actually hoping people will ask more questions. So this is a patient who's a 67-year-old divorced man living in rural Michigan with history of hypertension and chronic back pain, who you've been caring for in the past 10 years. In this example, I'm creating the perspective of you as a clinician in primary care. He called the clinic to request a follow-up visit. Your clinic is minimizing in-person care, and you scheduled him for an initial visit via video. During the visit, he says that he's not been doing well because he recently lost his job as a restaurant manager. He's been at home feeling socially isolated, and he's been buying prescription opioids on the street. He constantly is thinking about taking opioids. He's not been able to cut down on his own. And so what are some of the next steps to approaching this? What I'm hoping to emphasize here is that when you deliver care via telemedicine, or telehealth, be it phone or video, the key principles of care are still the same. You're still doing a good clinical assessment, asking questions, making diagnoses. So asking detailed questions to ascertain if he has an opioid use disorder or not. The other contributors to his current presentation, all of the things that we typically do as clinicians, that really doesn't change at all. And those are just as important, if not more important, when you're conducting care at a distance. For this patient, he also describes comorbid symptoms such as depressed mood, insomnia. He also reports some other substance use, including intermittent cannabis use, but not symptoms of other substance use disorders. He has had some experience with buprenorphine, which he got from a friend and found it helpful, but he's not been able to take it consistently. So what might you recommend? Sometimes it's really nice where we can actually have more interaction during these cases. Unfortunately, I think we're a little bit more short on time here, so I'll try to highlight some key points. One is, first of all, what this person is describing in terms of taking buprenorphine from a friend could be labeled diversion. Or it could be labeled kind of misuse. But it's important to note that most people these days have had exposure to medications like buprenorphine that are not prescribed. And oftentimes that can be helpful for us because it's a sign of whether or not they tolerated it. Diversion itself can still be a major issue and comes up a lot actually from rural colleagues. And that's an issue we can talk a little bit about if folks have questions. But in this case, it's actually a helpful experience that he's disclosing to us. So for this patient, you describe medication options, specifically buprenorphine naloxone as the first-line treatment. You do ask about his ability to do a urine screen and to obtain other lab work, including comprehensive chem panel, liver enzyme tests, things like that. And you discuss the availability of other resources, including community supports like Smart Recovery, AA, things like that, which at this point are very widely available via online resources, which I think the next CORA talk will be talking about. That's actually been a huge benefit, I would say, for a clinic, for a patient population, the availability of some of the other support resources online virtually. Different patients have different experiences with them, but it's one thing that we can easily offer. You can also consider referral to psychotherapy for opioid use disorder or comorbid depression if interested. Obviously, you would want to be doing this via telehealth as well. Okay, and so let's say that you've been doing telehealth, prescribing buprenorphine via video visits with this patient for a while now. They've been doing generally well. He has been completing urine screens at a clinic close to him or at a lab close to him and having those results faxed to you. However, at this point, let's say he calls you again and he says that he now has major challenges doing the urine screens because he has lost access to his car. And he's also been really trying to social distance. He does report openly that he has occasional times where he's been using cannabis and other prescription opioids. And so the question that I think, going back to the question that was asked before, is how might you could be considering assessing this person? What if you have a patient who you've been seeing virtually who is having trouble doing urine screens at the frequency that you typically recommend? How would you approach that? I'd be interested in any comments on this topic or any experiences from folks in the audience. The general approach that I think, the general way to maybe think about it that I found helpful is this, which is, think about what is the specific reason why you want this particular test or assessment. Most commonly a urine screen. How would the potential results affect your clinical decision-making? Meaning, regardless, so if the results come up positive for opioids and cannabis, does that affect your decision-making? If the results are different than that, are there certain types of results that might make you think one way or the other and affect your treatment recommendations differently? That's kind of, I think, the most important thing that guides whether or not and how often to require or recommend those. But then on the other hand, the other question that we oftentimes don't ask ourselves is, if you place a requirement and the patient is unable to do it, what are going to be the other options? And are there other ways of assessing the things that you're most interested in addition to that urine screen, if that's really not a possibility for the patient? And so those are the things that I'll highlight a little bit. Okay. This slide, I'm sorry, in some ways I'm going a little bit out of order, has some also resources for broadband and internet access from recommended from HRSA and resources that might be helpful to patients as well. I'll go back to, I'll skip ahead to the urine topic just because I think it comes up so often. And so I think the key things to think about are things about we might have all been used to having patients complete urine samples or urine testing in our clinics before COVID. And since COVID, especially with telehealth and with social distancing, a lot of us have had to change our practices to where even if patients are able to do urine screens, they're oftentimes not able to come in person. Otherwise, we would be seeing them in person. And so sometimes that means that they're completing urine screens at outside labs, having those faxed over. This is not an easy thing oftentimes for both patients and clinics. So there are challenges with that. The broader question is, how often is urine toxicology required? And the key thing is that monitoring is required. It's required, an important part of any treatment that we deliver, that we monitor and understand patient response. So that's the most underlying thing. And urine screens are one tool and a very important tool in that toolbox. But there are other things that might be helpful too. With that said, there are oftentimes health system-based regulations and also potentially regulations related to reimbursement that might say something about urine screen frequency. So it's still important to check within your local communities for that. However, in addition to urine screening, there are other ways to help monitor for progress. These include, most importantly, are the basic clinical skills that we have, which is assessing how patients are doing. I find that when kind of the approach is trying to develop that relationship with the patient and having patient report their use and how they're doing overall, and doing that in a very open-ended way, it's quite, many of us are very likely to get pretty honest reports from our patients when they feel like they can tell us about all the things that they're using and all the things that they're experiencing. So I think that's a very, very important clinical tool to have. You can also contact and obtain collateral information from families and other folks that the person is living with. The key definition of addiction is really having functional impacts. So when folks are struggling, there's oftentimes many other signs besides a positive urine sample that they're struggling. There's other ways of monitoring. So one approach that I know a lot of clinicians have taken to is actually having patients do urine monitoring on their own at home. They can potentially share the results with you via video. Obviously, there are major issues in terms of the validity of urine dipsticks that a patient might purchase from the drugstore. But sometimes in lieu of other options, that's one thing that people have considered. The main point here is to consider options as a whole. What's actually going to be available and feasible for patients? What are the most important questions that you're asking? What are the requirements for these things in the particular context that you practice? And what is really kind of the goal of care? So those, I think, are the key things to consider when it comes to monitoring patients in the setting of telehealth. So there are other topics that we can talk about. I'm really sorry that I've gotten so close to the end of this talk. I think there's lots of other helpful clinical questions to address. I'm happy to take one or two questions and happy to also answer any other questions over email.
Thank you so much, Dr. Lin. I'm just going to take a brief moment to launch the poll. And I don't know what your schedule is, Dr. Lin, but if you can stay on longer to answer questions, or we can end at 1, totally fine.
I'm happy to stay on maybe 5 or 10 minutes longer if folks have any questions.
Thank you. So I'm launching that poll now, and we appreciate any feedback that people can give. And if your question doesn't get answered in the next 5-10 minutes, or if you have to log off for another commitment, that's totally fine, and we can answer it over email.
I'll also kind of turn to these slides. So at the end of these slides, I try to include a number of resources that can be very helpful for both clinicians and patients. Hopefully these slides can be made available to folks in the audience if they're more interested in practical recommendations and guidelines and such to conduct telemedicine for substance use disorders.
Thank you. That's really helpful. Yes, we will be providing these slides to people. Okay, so Dr. Lin, are you ready to take some questions? Yep. Excellent. Okay, so one person asked, let's see. So one person asked, is there strong evidence for naltrexone reducing death for opioid use disorder, meaning Vivitrol? And a related question might be, is there any data on how many opioid overdose deaths are in people that have Suboxone and or methadone in their system?
Those are good questions. I'll answer them in parallel. So we do have a few studies that have recently come out that have shown the mortality benefits of buprenorphine and methadone, meaning when patients are on buprenorphine and methadone, so not when they stop it, but when they're actually retained in treatment, those periods of time are associated with substantial reductions in death rates using pretty rigorous data sets. So for example, the entire population of people in the state of Massachusetts who had experienced a prior overdose and all those, so other recent data sets. That study did not show a mortality benefit of naltrexone or Vivitrol specifically. There are some limitations of that, partly due to just kind of Vivitrol being much less used and some other challenges. So I would say that we don't have kind of that data to support those impacts of Vivitrol to date. And that's why I think it's really important to have all three treatment options. You know, some patients really do much better on some than others, and some are just more feasible for some patients too. Oh, I'm sorry, I didn't ask the second one, which is remind me.
Is there any data on how many opioid overdose deaths are in people that have? Yeah.
So what's interesting? So I can't answer that one directly, but what's interesting to note is that the one trend that has actually gone down in terms of overdose rates are people who have overdosed with methadone in their system, right? So we do know, so sometimes people ask me this question in the context of diversion, meaning, okay, if we make, you know, methadone and buprenorphine a lot more available, and many of us do work and have been, you know, worked with patients who we are very concerned about them misusing their buprenorphine and such. Is that one downside? And it certainly is, and it's really important to think about that. I've done quite a few research studies, and there's a couple of research papers on this topic. With that said, there hasn't been any evidence to date to show that the overall potential downsides of diversion, meaning misusing methadone or buprenorphine, meaning sharing it with friends, or taking it not as prescribed, that has caused any more problems than not in treatment. In fact, I would say that we're much more on the other side of things, which is still that not enough people are on these treatments. Methadone in particular, like I mentioned, that's the only opioid where rates of mortality have gone down a lot over recent years, showing that it's just that, you know, a lot less people have access to it. The other thing just to highlight about these types of studies is when I say that someone has buprenorphine or methadone on board, it doesn't mean that that's the substance that killed them. There's lots of causal interrelationships that we all know. And so, and it is a challenge oftentimes. You know, I do have a number of patients who are oftentimes struggling even in buprenorphine treatment or on methadone treatment. It's not to say that these treatments are perfect by any means, but it's to say that on average, we believe through lots of research evidence that on average, these treatments should be offered much more widely and on average are more effective than any alternatives to date.
Thank you. That's an excellent. We had a comment. This comment says, we typically have folks come in for cheek swabs on a random schedule. The results determine the intensity of our focus, and we do work with patients who struggle with transportation. And just wanting to let you know, we have a few comments like that coming in, and we have people thanking you for your presentation. There is one other question, if you have another minute or two, that I could share. This person says, fentanyl can override buprenorphine blockade. Is there any data on efficacy of the usual 16 milligram bup dose? This is not about telehealth. With today's fentanyl-laced drugs, is there any data on changes in frequency of opioid point of service or POS urines in patients on bup? When UDS are addressed, please comment on the role of saliva testing.
Okay, so there's, I think, at least two questions, maybe.
Yeah.
The first one about fentanyl and the buprenorphine dose overcoming blockade, I totally agree. So in Michigan, where I work, the vast majority of my patients are positive for fentanyl and other synthetics. And that's made it very challenging for several things. One is actually sometimes even with starting them on buprenorphine can be challenging. It could really precipitate withdrawal much more often than I think before, when we were not faced with these very potent opioids. And so I have had a smattering of patients really have a hard time with getting started. The one approach that there's gotten a lot more interest and support for is the microdosing approach. So starting at smaller, more frequent doses. There's a couple of papers published on this. Usually they're case reports because this has not been widely researched yet in like a randomized controlled trials. But if you look on PubMed for microdosing like protocols for buprenorphine starts, there's some good guidance for how you might do that. The other question I think has to do with like just dosing buprenorphine in general. I think there might be some evidence to suggest that different patients, some including those who are using more potent opioids, might need different doses of buprenorphine. The traditional recommendation is kind of the higher doses of around 24 milligrams. What I would say in general is that in my practice, it seems to be very patient specific. There are patients I work with who are using predominantly fentanyl products and who don't necessarily need like extremely high doses, but then there are others who really benefit from that. The other thing that's actually gotten to be more challenging is because of that, like starting people on buprenorphine, it seems like it's not just the maximum dose that's important, but it's actually how quickly we get them there. And that's very challenging. And honestly, it is a challenge with patients who you're not seeing in person. I would actually say that would be a challenge for in-clinic patients too. For example, if you had a patient who was hospitalized that you were doing this, obviously it would make you feel a lot more comfortable like starting patients and using some of these different regimens. But the one thing is that there are now decent case reports that are being published of how different people have approached some of these challenges, and those are good resources to read. And then, I'm sorry, the last question was about different types of monitoring. So not just urine screens, but other means. I think it's really, in general, as many tools as we can have in our toolbox. So if a patient can do a cheek swab or can do another saliva test, that's great. Oftentimes we were doing that in our clinics, which if you're doing telemedicine, that would be hard. There is actually quite a lot of research being done on remote means of monitoring. So can we use wearables, sensors, things like that? Unfortunately, those are not widely available today. The thing that's most widely available, obviously, are the over-the-counter testing, which patients can use a dipstick and show you. The hard part of that is that comes oftentimes with false negatives, false positives. So you always have this question of what do you do when you interpret results? The thing that I want to emphasize the most is that was always a challenge in our jobs. It was always hard to figure out what we do with any result. And so what I think COVID and telemedicine really emphasizes is it's really important to think about all facets of it. Like, what are the pros and the cons, depending on all the things that you could potentially do. If you choose X route, meaning if you choose to continue buprenorphine, or if you choose to ask for a urine screen, how would those results affect things? If you choose to decrease frequency, how would the results affect? And what are some of the other options that you can do? I think it's a real testament that we have a tough job and that there's not necessarily like very clear cut right or wrong answers. And it really has to do with the patient specific. And that's why no matter if we see our patients via telemedicine, I still strongly believe in the importance of rapport, of trying to be as open as possible to where you feel like the patient is able to tell you as honestly as they can, given their illness. And so I guess just to emphasize that there's different variables that we have and different tools that we might use in some of these circumstances.
Thank you. Thank you so much. This is wonderful, and we do have to close, but we appreciate so much, Dr. Lin, that you came and you gave us all of that very interesting information. Everybody is very appreciative and thanking you. So thanks to everyone who joined today. You're going to receive an email in a few days with the recording and the slides for this webinar. And with the slides for this webinar, and you're going to get instructions on claiming continuing education credits. If there's any questions that we weren't able to address, we will do our best to follow up with you. And as always, if you have any further questions or comments for Dr. Lin or for CORA, please feel free to contact us at cora@uvm.edu. Have a good day, everybody.
And just a quick plug, Dr. Lin, if you could go to the next slide.
Sorry about that.
No, you're totally fine. We have a very exciting, just keep going for the next, there we go. We have a very exciting session happening on September 8th. It'll be a panel discussion on peer recovery as an evidence-based practice. We're very excited to welcome Dr. John Kelly, Dr. Mark Detman, and Liza Ryan from a local recovery center to talk about peer recovery in many different formats and settings. The registration is now live. If you go to go.uvm.edu/peer recovery, the registration should come up. And thank you again for attending today.
Thank you. Bye.
Bye.